I'd like to call upon Dr. Lena from Marseille. Are you still in Marseille? And he's going to talk about treatment of Chiari 1 malformation in a series of French patients.
First of all, I'd like to thank the organizers and more specifically Laura Valentini, who has allowed me to hold a speech on a disorder that's fascinating to all of us and to share with you my experience. I am supposed to just report to you about Chiari malformation accompanied by syringomyelia, not just syringomyelia. Here on this slide you can see all the surgical techniques that have been proposed in the literature up until 1995. When consensus was reached as to the fact that treatment was physiopathological and required spinal decompression. As far as I am concerned, I have performed all types of surgery listed here, except for terminal ventriculostomy. I've done all the rest. But today, I'm just going to focus on the modern treatment of Chiari malformation and syringomyelia patients. I have just seen cases who first had a craniocervical decompression. 40 patients were treated with this treatment in the first instance. I just saw Chiari 1 patients, and you can see that there are different extents in the syrinx that can be present. Of course, we're not talking about Chiari malformation and bone or ligament anomalies, such as this one, where the approach is likely to be anterior. In all these Chiari and syringomyelia cases, this is a child that was treated for atheromoid cyst of the cranial posterior fossa a few years before he came to our observation with hydrocephalon and enlarged ventricles. I'm not going to talk about Chiari and syringomyelia with posterior fossa tumor, because treatment involves treatment of the tumor. And we're not going to focus on Chiari and syringomyelia, such as this recent patient whom I saw last year with complex craniosynostosis. In some cases, in 97 patients, this occurred. As you can see, there is a cyst at both levels, which healed, but Chiari was still there. Chiari's malformation was still there. In our case series, there were 5 children of less than 5 years of age, but nearly 70% of them were children older than 12. Diagnostic range or diagnostic delay was 1 week of hydrocephalon appearance, especially in the small patients, and 132 months for adolescent patients, one adolescent patient who had been monitored by an orthopedist colleague of mine due to scoliosis. Symptoms are well known to me. What's important is that in our experience, scoliosis is very frequent because the majority of patients were referred to me by an orthopedist. Only those with a neurological symptomatology are directly referred to a neurosurgeon or neuropediatrician. Two patients were first operated on by their orthopedist before they were treated for Chiari and syringomyelia. This is one patient who was treated in 1997 and who came to us with pain at the upper right limb. X-ray showed this degree of syringomyelia. In 4 patients, diagnosis was incidental. This is one NF1 patient. On the left, you see his MR. He did it at 2 years. There was no sign of Chiari, but 7 years later there was Chiari's malformation, syringomyelia, and hydrocephalin. The most usual signs at physical or clinical examination are lack of sensitivity, anesthetized areas. This precise assessment is not possible in very young patients. It's only possible in adolescent patients. Some patients were examined very late and they had muscular atrophy. One of the most recent cases is the patient whose hand is portrayed here. He had been treated for scoliosis by an orthopedist, and when his parents realized that he had hand atrophy after 2.5 years of follow-up by our colleague who was an orthopedist, they sent him to me. In 70% of cases, they had spinal deformations that were very important. Cob angle had a variation of between 18 and 52 degrees. Locations were different. Mostly the site was thoracocervical. On the left is the cervical alone, thoracocervical in the middle, and hollow cord syringomyelia on the right. Surgical management spans a 20-year period. All patients underwent decompression with duroplasty. 8 patients underwent plugging of the obex. 4 resection of the tonsils. 3 hydrocephalus patients were first treated for hydrocephalus with a shunt and a ventricular peritoneal shunt in 2 cases and a third ventriculostomy in 1 case. And 2 patients were 2 complications that I'm going to illustrate later on. As for the technique I use to prevent leakage, I open the aponeurosis this way. In Y mode, what's important to me is opening at the level of the foramen at a very anterior site in order to achieve a considerable decompression. If I can avoid opening the dura, I do, but if it has to be opened, I open it. It's not a problem. And then I proceed to dura coagulation this way. Afterwards, I usually explore the fourth ventricle, depending on the MR picture, because sometimes the dura is very thick, and that's when I prefer to open the dura itself. So I introduce a layer of Gore-Tex without fixing it below the dura. I tightly close it so as to prevent CSF leakage. And then when I've closed everything, I perform a Valsalva's maneuver. After that, I can be sure that there's no CSF leak. In some cases, I've performed a plugging of the obex. This is a pyramidal that blocks the fourth ventricle. And I've always found a communication pathway between the fourth ventricle and the cyst. When syringomyelia was located at the cervical site. This is an old patient dating back to 1996. Here I performed decompression and plugging of the obex, and radiologically speaking, the result was perfect. The syrinx collapsed perfectly. This is one patient on whom I performed a tonsil resection. When do I do it? When there is no tonsil fixation, and when tonsils are distended below C2, I do it systematically. I do it every time. This is one patient in whom the cyst has been decreasing over time, and in the end his tonsils were no longer ectopic. This is another patient on whom I performed the same technique with excellent results. This is decompression alone with plastic, with a Gore-Tex Duraplasty. The result is, as you see, quite spectacular from the radiological standpoint. This is a shunt patient. It was a young child with intracranial hypertension due to hydrocephalon. We performed a shunt, and 2 years later his syringomyelia was still very wide. So we resorted to the decompression technique, and the result was successful. Complications are interesting to look at. Hiccup, we had 2 cases of hiccup and 1 case of diplopia. Both were transient. Both were treated with obex plugging. The same goes for hydrocephalus. 2 patients had a recurrence of syrinx and Chiari. This is one such recurrence. This patient in April had a very important syringomyelia. 7 years later, he began to decrease, and 4 years later, there was Chiari's malformation and syringomyelia again. So we performed a shunting technique, and there were 2 such patients. As for neurological results, they were good, clinically speaking. Only neuropathic pains did not disappear. As one of the speakers who took the floor yesterday said, this is the most serious problem when talking about results. There were 2 patients with progressive clinical deterioration. These patients were seen very late, came to our observation very late with very severe neurological damage. They came from Northern Africa. They often come from this country with a very long clinical history and a very severe condition. Let's look at results about syringomyelia. In more than 32% of patients, the syrinx collapsed. The same percentage had a decrease of more than 50%, and 30% had a decrease of less than 50%. This is one collapse. This is a decrease of more than 30%. It's a rather recent patient. And the last MR he did last year looks exactly the same as this one. So there was no decrease, I suggest, no decrease of the syringe. Here you see different syringes. One is very high up and doesn't seem to communicate with this other syringe. This is collapsed thanks to a remarkable decompression. In the upper part there was also a collapse, but lower down a syringe increased in size. Let's look at results about spinal deformities. Improved or stable patients amounted to 85.7%, and just one patient was operated on. Perhaps we can discuss this with our colleague, the orthopedist, who's here. The first patient was operated on very early. This angle was not a good orthopedic indication. The other patients had a very high COB angle of between 40 and 52%. Conclusions. In our experience, scoliosis is one of the most revealing symptoms, and it appears in 70% of patients. Decompression is the first choice treatment worldwide in patients with Chiari-1 malformation and syringomyelia. If hydrocephalus is present, it must be treated separately, and recurrences are possible. This means that in children who need to be followed up over time, you know, I thought that years ago, I thought that children could be cured, but syringomyelia can actually recur and is a long-lasting disorder. Thank you. Thank you, Leonard. Now it's time for questions and answers. Perhaps Dr. Colombo might want to add a couple of remarks. Congratulations, you're my best Italian language pupil, Italian language student. What have you done when there was a relapse after tonsillectomy? I've seen a list of many surgeries, but I haven't seen any retroperitoneal syringomyelias. In the 2 relapses, I did retroperitoneal shunt. And what was the outcome? The cyst did very well. It worked very well. Why don't I carry out a retroperitoneal shunt as a first choice surgery? Because me and my colleague performed a retroperitoneal shunt as a first choice treatment, and terrible intercostal pain was suffered by the 2 patients, so we had to remove the shunt. And the pain began 4 or 5 years after the shunt. They had such terrible pain. The cyst formed again, so we opened the posterior cranial fossa at C1, and the cyst disappeared. So we decided to always perform a decompression as the first choice treatment. I would like to add that so far during the conference it has been taken for granted that in Chiari and syringomyelia patients the first treatment to be performed is craniocervical junction decompression. Congratulations for your presentation that you held in Italian. Does the clinical state always go hand in hand with the radiological picture? That is, do patients do well when their radiological picture is good? I would like to know whether a reduced syrinx always leads to a neurological improvement. When there's paraplegia or a pyramidal sign, they go back to normal. If not pain, pain always goes away in children as well. If sensitive disorder persists for children, it's not so disabling, not so important. Anything else? Good, thank you. Now.